Hi, everybody. Lisa White, IVF coach and creator of IVF Manifesting a Miracle, here for a clinical conversation with our friend, Dr. Greene. Hi, Dr. Greene.
Hey, how's it going?
Good. How are you?
I'm doing well. So you are in like isolation, but not officially quarantined, correct?
Yes.
I mean, maybe we should start with a brief update about COVID.
I would love that. Yes, I'm not at risk or anything, but my daughter was exposed on Friday at school. So her school let us know we cannot go back for another week. So had a COVID test for her today. She's negative, thankfully, but following the protocol, you know how that goes. So.
And I think that's an important thing, here in Colorado, for people that aren't aware, there is a statewide program for people that have kids in school that you could get free COVID tests. I know that they're a little bit back ordered, but you can go to the website there and get COVID tests sent to your home. And that's sort of a helpful thing as well.
Yeah, thank you. Yeah, I'd love if you could share an update on anything COVID related for us.
Yeah, well, let's talk about pregnancy, because that's what's really on my mind today related to COVID.
Yeah.
It's kind of sad and frustrating. Only 1 in 3 pregnant women has been vaccinated, according to the most recent statistics from the MMWR, the branch of the CDC that tracks these things. Now, the reason that this is important, women that get COVID first of all, women that are pregnant are much more susceptible to the infection being severe than women that aren't. They're at much higher risk of preeclampsia and preterm delivery. There's no increased risk of miscarriage in the first trimester. So it's in the third trimester of pregnancy, the risks are greatest. They're 5 times more likely than women that aren't pregnant that are the same age to wind up in the ICU. And they're 22 times more likely to die than if the same person got COVID and was not pregnant. In fact, this year alone, over 160 pregnant women have died from COVID simply because they weren't vaccinated. And in August alone, there was a 3-week period of time that 22 women in one state all died of COVID during pregnancy just due to lack of vaccination. So bottom line is, COVID is dangerous. The vaccines are safe. They're safe for use during pregnancy. They're safe for use during breastfeeding. And if women get them during pregnancy, you're also letting antibodies cross the placenta or into breast milk to protect your baby. So please get vaccinated.
And there's a safe time at any time a woman is trying to get pregnant and in pregnancy to get the vaccine, are you saying?
Correct. Now, keep in mind, there's 3 vaccines that are available. As you and I talked about previously, I am not recommending the J&J vaccine, only because there have been some rare episodes of blood clotting issues in reproductive age women. And obviously, our target audience for this video is reproductive age women. So I think it's a safe vaccine, but let's just use that for the older people and the men. And there's safer alternatives, which are the mRNA vaccines, either Pfizer or Moderna.
Okay. Well, thank you for sharing that.
Yep.
So today's topic, it's a really hard topic to talk about, recurrent pregnancy loss.
Yeah.
And I have clients that have gone through it, many fertility sisters. It's very sad. I mean, I personally have not experienced it, and I don't know the depth of that loss, but I'm hoping, I got a lot of questions sent in to me. And do you have any thoughts you'd like to just start off with?
Yeah, well, first of all, I did experience that with my partner when we went through treatment. Our first pregnancy was not a success. So I've dealt with the thoughts and the questions, most of which you can't really answer on an individual basis. But what I've learned to do over the years, and this is how I've continued to build greater and greater success and understanding over the years, I think of what we do, and we've discussed this previously, as almost like an engineering issue. We try to identify as many variables as possible. And then once you identify the variables, then you can start to create potential ways of testing or treating these variables. So the way I talk about this when I explain to patients issues related to pregnancy, I break it down into 4 categories. Okay. And we can talk about these independently, and some of them we have talked about. but then, we could also go into deeper dives at a separate time. But the 4 categories are: number 1, the embryo; number 2, the uterine environment; number 3, the period of time leading up to and including implantation. And if it's, pregnancy through a frozen embryo transfer, you can also call that the protocol. But if someone's conceiving naturally, it's the time leading up to and at the time of implantation. So you can call that peri-implantation. And then category 4 is what I call post-implantation failure. Mm-hmm. And these are things that happen after the embryo has already been established and the HCG levels are strong and have been rising. So those are the 4 categories that I look at when I think about considering pregnancy. And the 2 that are most relevant when it comes to miscarriage, because obviously if implantation has already taken place, the 2 that are most relevant are the embryo and post-implantation. But there is some emerging data that even the uterine environment might have some impact post-implantation as well. And that's why, I use that as a separate category than the protocol or the pre-implantation. Does that make sense?
Yeah, thank you. So you mentioned the embryo. Let's maybe start with that. And one of the questions sent in about the embryo. So what are the possible reasons why a PGT normal embryo, quote normal, can still result in miscarriage?
Yeah, well, first of all, words are powerful. I never use the word normal.
That's why I put quotes. Healthy.
Yeah, and honestly, and I know it's very common for people to use that, but the reality is, according to most recent data, there's at least 16,000, and the older data suggested 22,000 genes involved in the human genome. To me, if we're going to call an embryo genetically normal, that implies to my ear that we've tested each one of these genes. That's not what today's testing is about. Today's testing is simply looking for missing or extra DNA. Okay. And the reason is because these are the most common random abnormalities that occur, and to use a good analogy, although this is getting kind of dated. I'm an older guy, so you probably have never seen encyclopedias. Do you remember encyclopedias?
Oh, yes, of course.
Okay, well, encyclopedias, if you think of each gene as being like a separate encyclopedia, okay? Mm-hmm. And if you have 2 complete copies, okay, and each one represents 1 gene, what you're looking for with today's genetic testing is you're quantifying that there's no missing or extra chunks of data in there. But imagine when we're testing individual genes, that's like opening to a certain page in a certain volume and reading and make sure that the information in there is accurate, okay? Mm-hmm. Mm-hmm. And so the point is that sometimes, even if you have all the right amount of information, there could be some mistakes in some of the details. And imagine that some of those details are the instructions to certain cells to become heart cells or liver cells or whatever. Then you could have normal volume of DNA, but still have a point mutation that can make an embryo fail. So that's one reason that a genetically tested embryo can fail. So I use the word euploid spelled EUPLOID, meaning there's no missing or extra DNA, or aneuploid, which means there is missing or extra DNA. So today's testing is usually only testing for euploid or aneuploid, unless you're testing for a specific disease that we know somebody has. So that's the first thing. The second thing is, there are many things that today's technology does not allow us to test when we're testing an embryo. One is the gene turning on or turning off at the appropriate time? And that's a whole emerging field that we call epigenetics, okay? If a gene turns on at the wrong time during our adult life, we develop a tumor, okay? If a gene turns off at the wrong time, we develop premature signs of aging in whatever disease system that's going on. And so this is even more critical during embryos and, during the embryology phase. And so epigenetics, this field of turning on and turning off genes, which is not currently testable at the embryo level, is one of the things that can make an embryo that passes the DNA test still fail when it comes to implantation or ongoing pregnancy. Because again, for instance, and I'm making up just simplistic models, but imagine all the genes that tell the placenta what to do turn on at the right time. But if the ones that tell the embryo what to do don't turn on at the right time, you could wind up with an empty sac where you have a placenta and no embryo. You see what I mean? So we've talked about the DNA, we've talked about the epigenetics. A third thing is is an emerging field of what's being called metabolomics, testing the metabolism of the embryo. And again, this is, another emerging technology that might be available in the coming years. But currently, we don't have a way of testing that. But one of the things I could tell you that we do at our center, we always do a viability test before we put in an embryo.
What is that? Centers, viability test, what does that look like?
Well, basically what we do is we thaw the embryo an hour or two before the transfer to make sure that it's expanded fully and that it's functioning, at least visibly, in all the ways we want to see. I could tell you, I'm amazed that some centers will just thaw an embryo and put it in without even being sure it's alive after being thawed.
Wow.
Nationally, it's estimated something like 96% of embryos survive freezing and thawing. But some centers, again, if that's average, that means some centers it's maybe 90%.
Wow.
At our center, 99.4% of our embryos survive freezing and thawing, but we still test them all because, 0.5% of the time it doesn't survive. And we need to know that before we put the embryo in.
Thanks for sharing that. Okay.
And so, and on top of all this, there's probably even other things about embryos that we don't know. But the point is this is why I don't like to use words like normal, because today we're able to get a lot of good information about embryos, but there's still a lot that we don't know. And a certain number of early miscarriages, especially in untested embryos, are considered an embryo failure. Meaning that it was nothing that the woman's body did wrong, but the embryo failed. And we can't always know whether it's an embryo failure, but we can, at least if the center is doing a viability test before the embryo is placed.
Okay. There are individuals I know that have many PGTA healthy genetically tested embryos, and multiple miscarriage, say 7th and 8th transfers. Is that common? I mean,
well, it's not common. It's tragic, because we do see that happen, but I would not use a word like common. So when we're talking about miscarriages, we're talking about post-implantation failure. Okay. So what that tells me is that the peri or pre-implantation phase is working out properly. So, whatever they're doing to get the embryo to implant is working. Okay. Now, some of the time, those can still be related to the embryo. Okay. Like, for instance, some people can have what's called a balanced translocation. Now, a balanced translocation means they have all the right information, but it gets shuffled up a little bit. And sometimes it can actually get shuffled up in a way that is not balanced. And not all testing methods can detect this. And this is why, whenever someone has had multiple miscarriages, both the male and the female partner should be tested to make sure that neither one is a carrier. Okay. Because people that have a balanced translocation, on average, will have one live birth for every 5 to 6 miscarriages. So even if they're conceiving naturally, people with a balanced translocation could have success, but it's a much lower chance of success. Okay. And so that's why, that again, just because the embryo has been genetically screened if either person has a translocation and they don't know it, and the embryos aren't being tested for that, you could get, a false positive on, if you're just testing the quantity of DNA present.
That's a separate test, the translocation.
Yeah. Well, basically, both the male and the female partner would have to have what's called a karyotype.
Okay.
To look and make sure that neither one of them has a balanced translocation. Yeah. Okay. So that's one of the things from the embryo standpoint that could result in balanced translocation. A second thing is, when it comes to, we were talking a moment ago about issues of epigenetics.
Yep.
The epigenetic changes are inherited. And so sometimes one whole group of embryos could have a negative or a positive epigenetic change. So there are still possibilities of problems within the embryo. And so sometimes, you need to actually start with a different group of embryos. But the other thing that's important to consider are some of the post-implantation failures that can occur.
Okay. That's common. I have some clients that, they've gotten to the heartbeat. Then the second heartbeat, they don't hear, maybe they've made it to 6 or 7 weeks. And there's no answers.
And this is where the field of reproductive immunology is really emerging. That a person's immune system is really how a woman's immune system responds to an embryo is something that's critically important in success. Let me explain this in very simplified terms. A person's immune system's primary function is to identify and attack anything that's not genetically identical to that woman. Okay. Now, most of the things that are inside your body that are genetically different that don't belong are either viruses or bacteria or parasites. But occasionally, even a tumor, part of how our body's immune system helps prevent tumors is if there's a genetic changes that causes a tumor, that your immune system should attack it. Okay. That's a healthy immune response. Now, keep in mind in pregnancy, every embryo is genetically different than the woman that's carrying the pregnancy, even when it's created from her own egg. And this is why sometimes a parent can't donate a kidney to a child or vice versa, even if they have the same blood type. It's because there are immunologic differences between the two. Okay. Now, what's important is what we understand today is that when a woman's immune system first addresses and notices an embryo, we need for her immune system to not only accept the embryo, meaning not attack it, but we actually need for her immune system to help improve blood supply to that embryo. Because an embryo is struggling during those early days post-implantation, okay? And this is why the old model of trying to suppress the immune system with steroids didn't work at preventing miscarriages.
You're hitting a few questions I got. Exactly.
Well, this is what I'm saying. That's why we need the immune system to not ignore the embryo. We need it to help the embryo. Now, keep in mind, if your immune system did this elsewhere in the body, it would be promoting the growth of a tumor or an infection. So this is why suppressing the immune system rarely works, because we need the immune system to be participating. And so some of the latest science has been, and it's way too much detail probably to go into in one session, is how can we help a woman's immune system help respond appropriately to an embryo? And you and I have had previous discussions about one of those methods with intralipids, which basically targets one type of immune cell.
Right.
But what I always tell people is, if you think about the fact that your immune system is protecting your body, I compare that to like the armed services. We have the Army, the Navy, the Air Force, the Marines. They're all protecting us, but they do it a bit differently. And there's different types of immune cells that are protecting a woman's body, but they're doing it differently as well. And the intralipids are one tool that we use to try to help in these situations, but they target only one of these type of immune cells. And part of what we're learning today is there's a whole host of things we're learning that can really help improve the outcome in people that might have underlying reproductive immunology issues. The other thing that I think is also just mentioned, I want to mention briefly, that's also a post-implantation, is sometimes issues related to coagulopathy. That again, if an embryo is implanted and it's growing, but a very, very small blood clot, something just a little bit bigger than a period on a typed page, a blood clot that small at the wrong time, at the wrong place in a developing embryo can really wipe out a major blood supply for that embryo. So there are some, but although less frequent based on today's, data, there are some situations where very subtle issues of coagulation, where the woman's blood is just a little bit too thick and causing clots in the wrong place, can actually contribute to some of these losses.
Yeah, I'm wondering, how many different immune protocols would you say are out there for recurrent loss? Are there many?
I can't speak to that because I only know the ones that we focus on.
Oh, you have a handful. That could be another topic. People are interested in that, but we did do a talk on the intralipid infusions. But
and the point is that one of the important things that I explain to people all the time is the way science has to occur is you have to start off with a theory. If you don't have a theory, you could never test that theory. And if you can't test it, you could never prove it, whether it's accurate or not. Once upon a time, the theory, and again, I've been in this field 26 years. Early on, the theory was we had to suppress the immune system in order to help an embryo grow. And that's why, for many years, everybody was using steroids. And I was always saying, what? If we're saying stress is a bad thing, why are stress hormones a good thing, And then finally, we had enough data, and the data showed, what? Steroids don't work. They don't prevent miscarriage, and they don't improve implantation. And that's why I haven't really prescribed, the prednisone or dexamethasone since probably about 2008. There are rare exceptions, but generally speaking, I haven't done that in over 15 years.
What about Lovenox? Anything on that?
Yeah, there's a lot on that, but that again is a very complicated subject. And to be honest with you, Lisa, if you would have asked me that same question as recently as June of last year, I would have said I'd pretty much abandoned Lovenox. But this is why we have to keep doing new research. There was a major review paper published in July of this year, July of 2021, that made me, it was a 36-page paper, okay? So it took a lot, and what it convinced me of is, like a lot of things, that Lovenox is not a universal tool that should be used on everybody, but there are definitely situations where I believe it could be beneficial. But if you would have asked me this question before that paper came out, I would have said it's not something that I would widely recommend anymore.
And one question came in, what we're talking about, medications. Any medications you would recommend, which I know it's like individual for everybody.
Yeah,
so
and that's really exactly why I can't make any blanket recommendations. But one thing I would say, and again, we can talk about the data that supports it in a separate email, is a couple of things. Number one, vitamin D. Vitamin D studies show that vitamin D levels between 40 and 60 nanograms per ml or ng per ml.
Okay.
We see pregnancy rates are highest and miscarriage rates are lowest in that range of 40 to 60.
Okay.
Okay. And it's estimated that might be a significant factor for some people. And ironically, it's because of, we believe, of the way vitamin D can influence both egg quality, which affects embryo quality, and the immune system. So two things we just mentioned.
Thank you.
A last thing that I would just say is, and we could go into this separately as well, is that in many situations, there's evidence that metformin is associated with higher implantation rates and lower miscarriage risks.
Okay.
But again, these are much more detailed topics, and I think we're going long already.
No, this is great. I know we're short on time, but a couple more questions. How do you determine when a patient should keep trying or potentially move to surrogacy or another option where she would not carry the pregnancy. Can you answer anything on that?
Well, again, this goes back to those 4 categories that I started off with: the embryo, the uterine environment, the protocol, and then the post-implantation. Each one of those has subcategories. And when I'm working with a patient, we run down each one of them. Okay. And I tell people what we know and what we don't know and how that relates to their specific biology. And then we come to that decision collectively. But it is very complicated. And that's why that's an individual case-by-case discussion in my center. Now, it may not be that way in other places, but I find that algorithms fail us in this because it's too complicated.
And the testing you would recommend, we talked about the balanced translocation test to test. That could be a test that you could recommend after recurrent pregnancy loss, see if there's some of those genetic karyotype you said. Any other testing you could recommend? Or
well, general testing is most people will test for generalized autoimmune problems, just to make sure, because if a woman has an autoimmune problem, she's much more likely to have an immunologic intolerance to embryos. Okay. So that's worthwhile. Also doing some very basic testing of the coagulation system to make sure there's not a subtle abnormality there. But we're also finding, for instance, that for people that have some of these more complicated issues, there might even be some newer tests that might be worthwhile. But like I said, it would take too long to explain the situations that, and they're definitely not something I'd recommend for everyone because it gets very expensive. You could end up spending more money on testing. And what's most important, and I guess this would be a real important caveat to testing. I always tell everybody, before you order one more test, you should ask yourself, what am I going to do differently with that result? And if the answer is you're not going to do anything different, then you don't need that test. A simple example is we went into intralipids already in detail. Yeah. If the answer to a test is you're going to do intralipids and you already are planning on doing intralipids anyway, you don't need the test. Yeah. Yeah. You know what I'm saying? Yeah.
No, and this is probably another question. It's too in depth, but there's a fertility doctor who recently had her own miscarriage. I don't believe her embryo implanted. And she talks a lot about T helpers.
Wait. If the embryo didn't implant, it wasn't a miscarriage. It was implantation failure. That's a different category. Implantation failure is a different category. Okay. That's why I was exactly sure.
I think she's doing something with her immune protocol and being very open and sharing what she's doing. And it could be another topic we talked about, but T helper cells and all kinds of things, natural killer cells, it can get really in depth. So
exactly, but that's a pre-implantation issue. That's totally separate.
Okay. Yeah, I believe it was an implantation failure now that I'm recalling. So, so much information. I mean, yeah.
Well, exactly. And that's exactly why it's not something that you can just simplify into 2 or 3 key points. What's really important is that each person hopefully would be working with a provider that is either insightful enough to have these detailed discussions or is also open enough to say, this is beyond what I'm used to. Maybe you should consult with someone that's more experienced in dealing with these issues. Because the reality is there's a lot of questions. And even if you don't have all the answers, that doesn't mean those questions shouldn't be acknowledged. And there might even be some potential solutions for. And I think that's the hope that people should realize.
And that would be like a specialist would be an immune specialist, or who would you refer out to or suggest people? If a doctor can't meet their needs, are there certain specialties that you?
Well, I mean, sometimes just a second opinion within the same specialty. I can tell you that I've worked at centers where people just don't do anything. They either blame it on the embryo or they tell someone they need a gestational carrier. And but it was their own unwillingness sometimes to acknowledge where their knowledge base was lacking. And I know other people that literally just pull out a shopping list and offer everything that, whether you need it or not, here's like 10 things and let's do them all. And by the way, here's a bill for that. And that's not the best way to proceed either.
No, I appreciate that you really take your time with each patient and really share the data and the research behind your recommendations too. So,
well, and the point is, each patient is individual.
Mm-hmm.
Now, each patient's partner is an individual. And what's even more critical is so is each embryo.
Yeah, yeah.
And so it becomes very complex, and there's not one simple answer to most of these problems.
I know. And I appreciate you. You've really gone into this and explaining a lot to help us with the 4 variables. There's so much more I'm sure we could dive into on more future talks.
Yeah, we've already gone longer than we planned.
I know. Thank you so much. If people have questions in depth about what you've talked about, send them my way at ivfmanifestingamiracle.com. And Dr. Greene, you're at Conceptions here in Colorado.
And if you want, at some point, we could try to dissect some of these things out in more detail, but so it's not my unwillingness to answer these, but I don't want to answer something inappropriately so that people start doing things that maybe are not in their best interest.
No, I appreciate you. People can reach you at enhancingfertility.com. And for our fertility coaching.
Yeah, in fact, I just recently posted what I think is a pretty good summary of reproductive immunology that people might want to at least listen to. It's a podcast that I think helps explain some of the science on this. And it's not even my podcast. It's on my blog that I post a link.
Okay. What's the name of the podcast you're on? Do you remember?
No, it's not a podcast I was on. It's one that I'm recommending, and I'm blanking on the name of it right now, but I got the link.
I'll put it in the notes. I'll put that in the notes here.
Yeah.
So thank you. This is really valuable for anyone looking for extra support on their fertility path or IVF. Reach out to me and book a free call, and here to help you. So thank you, Dr. Greene.
Have a happy day.
Yes. Thank you, everybody. Take care. Bye-bye.
Bye now.